Hi, it's Dr. Janet Pope at Room Now, and I have with me my friend and colleague, Dr. Jeff Sparks. So, hi, Jeff. What do you think of the meeting
Hello.
so far?
It's virtual again.
It is virtual
It's
again
been,
next year.
this is life.
Yes. Well, the thing is,
Well,
the good thing is we can see a lot of sessions
it's all archived. I think the hybrid and, the interface is never going away. So there you
from
go.
here on in. We can rewatch our triumphs and our failures.
Yeah.
So, I thought it'd be great to talk about Lung Now. So,
Yeah.
what's your impression with what's going on with rheumatic diseases, RA, and other rheumatic diseases, and the lung, and where are we headed?
Well, in a way, I feel like it's following a similar path as the cardiovascular story, where we're seeing that this is a bigger problem beyond just, I think it really started in systemic sclerosis this time, as far as, really being on the radar. And certainly over the past few years, we've been thinking about RA-ILD, but myositis is certainly contributing as well. And then I think this year, ANCA-associated vasculitis, really provocative abstract that did a careful look to see what the prevalence of ILD within ANCA vasculitis was, and it's about 15%. And this is not the patients that are having pulmonary hemorrhage. This is often in the background or even prior to the patients presenting with ANCA vasculitis. And these patients do have an increased risk of mortality. So I think this is, spanning different rheumatic diseases and autoimmunity and fibrosis. And, obviously we've got new drug treatments that might be helpful in these patients. So I think it's really exciting.
And going back to what you're saying, I think it was under recognized in ANCA vasculitis. And if you think pretty much everyone with ANCA vasculitis has CT imaging if they have a cavity in their lung, but
Yeah.
everyone gets a chest X-ray pretty much. So I think it's been under recognized. And I kind of think that there's when we go to RA, which is more UAP, although either could have
Mhm.
NSIP or UAP, and we look at Sjogren's and myositis and lupus, that it's higher in myositis than in Sjogren's and lupus. And it's the highest in systemic sclerosis and probably moderately high than in RA. It's one of those things where people do the same better. Well, many don't do better, but the same and stabilize over time,
Mhm.
or they go downhill fast or slowly with sometimes small incremental improvement. So when you're looking at a patient, there's two kind of things that I wonder about. Should we have a way of systematically screening at least high risk patients? That's the first thing. And the second thing is, when should we intervene from both immune modulation and later possibly antifibrotic? So big questions for you.
Yeah. Well, I have to say the field is moving pretty fast. From an RA perspective, the MUC5B promoter variant has, really taken hold, and it's relatively common. It's up to 30% depending on the population. And those patients really have a high risk of developing ILD at some point throughout their disease course. It may not be right when they're diagnosed. It may be many years later. But it does really tell you about sort of a subsegment of RA that might be at risk for that. I think the other development, of course, is the antifibrotics, which are really being used in IPF, and you wonder about RA-ILD, particularly the UIP subtype. So I don't think it's been presented formally yet, but the late breaker abstract of the Trail 1 study, really provocative. Unfortunately, did not meet the recruitment goals. I think a lot of it was related to the pandemic. So the overall primary outcome was not met. However, many of the secondary outcomes really did look like this has a really similar trend towards a similar effect as in UIP.
Right,
Another
and that's
interesting
pirfenidone that you're talking about. So we
pirfenidone.
already have approval for nintedanib, so pirfenidone's on the heels, I
So the
guess.
pirfenidone's coming, and then the INVILD trial looked at nintedanib, and there's an abstract. There's already a positive phase 3 study, many of which had autoimmune diseases. Many of those had RA, and then there's another abstract. I think the criticism of some of these studies is that they do a continuous measure of 6-minute walk distance and FVC, and certainly the p-values are low, but does it really mean anything? So there's a nice abstract at this meeting about kind of categorical changes in FVC that really actually mean things, and it really does look like this drug helps patients. So as far as who to treat and when, that's another question.
Yep. So that abstract you're referring to, so they looked at 5%, 5 to 10 or greater than 10% difference in FVC. And each time, not quite double, but almost double the amount of patients getting the less worsening, so to speak. So half as many patients worsening on nintedanib than placebo,
Yep.
looking at basically ILD with a pulmonary fibrosis type pattern and RA and some of the other CTDs from the InBuild study. So yeah,
Yep.
I think treatment is going to change. I think we are probably going to introduce immune suppression in many of these diseases earlier, as well as treating the underlying signs and symptoms of the disease, and then thinking of when's the right timing in each individual to add an antifibrotic, because obviously it's not for everyone. Little mild NSIP, no honeycombing, stable for 6 years might be stable for a long time. So I think one last thing to close off, and I wonder if it's that MUC5 gene. I have seen the last 2 weeks, 2 different patients. One has dermatomyositis, a bit of a scleroderma overlap, but mostly dermato, and the other is RA, and in both women, and in both of them, they have ILD that's been progressive, and both of them had a parent who died of IPF. So I think we're
Wow.
going to see those associations more so.
Yeah. Yeah, it's a common variant. And in our biobank, we actually tested everyone with RA for the MUC5B variant. So it was over 1,000 patients, and around 20% had this MUC5B variant. And confirming the other studies, we saw nearly a 4-fold increased risk for RA-ILD based on just one single SNP, this MUC5B promoter variant.
Amazing. Yeah. So I think you need to follow your work, Jeff, and follow us on Room Now. And I have my Twitter. Jeff has a Twitter as well, so you can follow us on that. So great.
It's Lung Now. This is Lung Now, right?
Lung Now. You got it. All right. Bye-bye.
All right. Bye.